Hi everybody, this is Dr. Alexander. I just wanted to come on and focus a little bit on the medications used in delirium. The overview video that is posted through YouTube is actually a really great introduction of signs and symptoms and causes, but I wanted to make sure to give you a little bit of application specific to pharmacy. So, just to recap, delirium and dementia are not the same thing, and you'll hear this again from me in class when we meet in person. There's a few differentiating factors, and I think the video did a good job of alluding to this, so hopefully you've listened to that first before listening to me. But a couple things I wanted to point out in terms of differences. So delirium can come up from multiple different causes, as can dementia, and we're going to focus on dementia in class. But one of the main things that you'll see differently is that episodes of delirium come on very acutely. They come on very quickly in a short amount of time, generally within hours, whereas dementia symptoms and memory loss associated with underlying causes of dementia will progress gradually over time. It's a chronic condition. It will not resolve. Delirium is fluctuating. Dementia, because of its progressive nature, because of its gradual nature, is very progressive. You'll commonly see frequent fluctuations in symptoms within delirium as people come in and out of consciousness, especially as they're disoriented. Dementia, sometimes patients can have symptoms throughout the day, but it's typically less prominent to see really wide fluctuations. As far as delirium's duration, it generally resolves within days to weeks, and it's usually when those underlying issues are resolved that you'll see the symptoms resolve. Dementia, though, is a chronic condition that is currently not curable, so you're not seeing that resolve. Other big things, reversibility. Obviously, if there's acute memory loss with delirium, if you address that underlying condition, you can fix and sort of see a return to baseline. Or in dementia, you never regain that baseline. Patients who develop delirium during hospitalizations actually have a very high mortality rate, somewhere around 22 to 75%, and a high rate of death following discharge. So it is a big problem, and they're looking at ways to prevent it. However, the medications that we have, that I'll reiterate at the end here, are just not great at preventing it. So we really rely heavily on non-drug measures, and it's important that pharmacists know what those are and can advocate for the best therapy, which is sometimes no therapy. Whether they developed delirium in an institutionalized setting, whether that be a hospital or a long-term care facility, or they are admitted with those symptoms, their outlook is not always great. In patients who are elderly or who are in that post-operative period, delirium can result in them staying in the hospital longer, having more complications, and ultimately that ends up leading to increased cost and long-term disability. So it is a big problem. As far as causes, I've highlighted the most common ones, at least in my opinion, that I see. Remember, we're thinking about dopaminergic, serotonergic, and cholinergic symptoms involved in that pathophysiology. So anything that disrupts that, and that's especially important when we get to the medication causes, you can kind of tease back and think through. Big ones that I see or have seen in practice, constipation is a big one, infection, specifically urinary tract infections or respiratory infections, and then anything that changes fluid balance. So that can be dehydration. A lot of times that goes hand in hand with constipation or urinary retention. And then things like hypoxia, hypoglycemia is another big one. And then changes in location. And that's especially common in patients who already have some sort of dementia. A lot of times you'll see these overlapping. So just because they are not one and the same condition-wise doesn't mean that they can't both be present in the same individual. You may have a demented patient, a patient with Alzheimer's, for example, who acutely presents with delirium. That's very, very common, and a lot of times that happens because of changes in location, but it can also happen because of things like constipation or infection. In patients with dementia who have those acutely worsening confusion symptoms, you probably always want to look at environmental factors first or sensory deprivation. As far as medication causes, again, we're thinking about dopaminergic, serotonergic, and cholinergic systems being involved. So it's not surprising to see the list here. Alternatively, agents on this list may impact other conditions. So our opioid analgesics wind up on this list also because they contribute to constipation. So it may be a side effect of the med that ultimately contributes to a non-medication cause. In my opinion, the most common cause of delirium as a medication-related cause are your anticholinergic agents. And we're thinking of our strong anticholinergics like our first-generation antihistamines, which are hidden in so many things. That's a big one. If you've not learned that Benadryl and diphenhydramine is the devil through your time in geriatrics, then we clearly didn't do our job, because that is a major, major problem for older adults. Other ones listed here likely are also showing up on the Beers list, and this may be somewhat of a reason why, contributing to those delirium symptoms. Diuretics, again, would potentially contribute to dehydration, so you can see a lot of overlap. As far as treatment, I just wanted to go through quickly and overview this one more time. So the very first step in treating delirium is identifying what's causing it and treating the risk factor. So eliminating as much of the risk factor as you can, and the video went through in great detail what those were, so I'm not going to spend a lot of time here. The second piece is providing supportive care and preventing any sort of complications. Again, we're not even into drugs yet, and we're already on step 2. And then potentially managing symptoms through the use of medications, but keeping in mind that the medications are not great. As far as supportive measures, these are critical. So one, modify the environment. We know that patients get delirious when they're disoriented, so making sure that their surroundings are well lit during the day, that it's dark at night. For patients who have memory loss, a great way to make them less agitated or less confused acutely is making things feel like home. So a lot of times you'll find that patients will be much more calm if they have a blanket that's familiar to them, or pictures of their family, or just anything that makes something that's very institutional feel less foreign. Correcting sensory deficiencies. So a lot of patients that I've worked with get very confused and agitated when they're unable to hear or see. So making sure they're wearing their glasses, making sure they can find their hearing aids. All those things are really important. And again, with lighting and noise reduction. Sometimes patients will become delirious simply because their days and nights run together. There's nothing stimulating. So making sure that they're appropriately stimulated during the day through cognitive activities like discussions about current events or word games or puzzles, getting up and moving, that will ultimately lead to them being more tired and sleeping at night, and hopefully getting their circadian rhythms kind of back in line. And then lastly, utilizing reorientation techniques like memory cues. So if people are disoriented as to the day and place, making sure that there's a clock available for them, making sure that there's a calendar. Every time you transition someone to a different setting, making sure you tell them, okay, Mrs. Jones, here we are, we're leaving your room at the ICU, and I'm going to take you down to this, whatever room for this procedure or whatever. And that's just a way of kind of reinforcing so they know where they are, and in the end may at least lead them to be less combative, although it may not resolve their issues completely. If we're forced to use drug measures, really the agents that we have available are antipsychotics. The most common you'll see from the typical antipsychotic, or the first generation antipsychotic, is haloperidol or Haldol. It's high potency. It's, in some cases, it's got mixed reviews as terms of effectiveness, but generally you'll see it being less sedating than more low potency antipsychotics. Then we've got our atypical agents, our risperidone, olanzapine, and quetiapine. Things to think about here: risperidone tends to be more serotonergic than dopaminergic. So it may improve negative symptoms of psychoses, and it's going to have fewer incidences of extrapyramidal symptoms, which may be helpful, especially if the patient has some sort of Parkinsonian syndrome. Olanzapine is moderately anticholinergic, and it's very, very sedating, which may or may not be helpful. And then quetiapine is sedating as well, and it has the lowest incidence of extrapyramidal symptoms, so it's actually preferred in patients with Parkinson's. In general, with those atypical agents, we're always monitoring for QT prolongation. And in general, the mantra, as always in our older adults, is starting low and going slow and tapering them once symptoms are controlled and really focusing on short-term use only. Depending on the patient, there may be some sort of paradoxical reactions that could occur. Their side effects, we're thinking about all those gait imbalances and extrapyramidal symptoms. And then if you think to the black box warning, this is not an ideal agent to use in patients with dementia. So the black box warning on antipsychotics reads that elderly patients with dementia-related psychoses treated with antipsychotics are actually at an increased risk for death compared to placebo. So it's not recommended in everyone, and may be detrimental. Something that's not on this list are short-acting sedatives. Those are really reserved for patients being treated for deliria resulting from seizures or from withdrawal of alcohol or of other sedatives. So those are not something that's commonly used. We're really focusing on antipsychotics. That is all I wanted to make sure to cover. So just quickly going through some of the pharmacy-specific recommendations, but keeping in mind that sometimes no drug is the best drug. Thanks for listening, and I'll see you in class.